Okay, so for the next, I don't know, half an hour, 40 minutes or so, I'm going to talk about basics of extracorporeal life support or extracorporeal membrane oxygenation, ECMO. These are my disclosures. I work in an ECMO center, have some maybe user bias, and I've done some consultancy work for Baxter, but nothing that's particularly relevant to this talk. So the story of ECMO goes back a long way, actually. The first case report of the use of the Bramson lung was published in the New England Journal in 1972, where they used this device here that you can see took up most of the room and managed to rescue a young man with severe shock lung following trauma. Managed to bring his airway pressures down from the 60s down to still fairly high, 35. Used the machine for just over 3 days, and happy ending, the patient survived. Now, of course, things have progressed so that this machine that used to take up half the room is now something that somebody can carry in one hand. We'll get into that sooner. Just to kind of set the stage about what we're talking about in terms of nomenclature, we refer to a broad swath of extracorporeal life support here that depending on, which can use the same equipment, but depending on how it's configured, comes up with different names or different modes. Mostly based on blood flow rate, we divide things between ECMO and extracorporeal CO2 removal, or ECOR. Although the truth is, it's important to remember that ECMO would be more properly termed extracorporeal membrane oxygenation and CO2 removal, because it does both things. And depending on how we configure it with a arterial limb as well, one can do pulmonary support just on venous ECMO, or you can add circulatory support by returning to the arterial side of the circulation. ECMO is essentially a modification of a bypass circuit, but rather than use for only a few hours, as is done on bypass, this can be used for days to weeks. And it's been extensively used in the neonatal and pediatric ICUs for many years. And as we'll see in the last 10 to 15 years, an explosion in enthusiasm and use in adult patients. So here's a schema of what it looks like most of the time. If you look at this figure on the left here, we insert usually one cannula through the femoral vein that goes all the way up to just at the border of the right atrium. Blood gets sucked out of that by a centripetal pump, then gets pushed through a membrane where oxygen is added, CO2 is taken out, and then the blood is returned more or less to the same spot that it was taken out, but now it's oxygenated and relatively decarboxylized. We can sometimes do this same sort of setup using a single dual lumen cannula. I'll show you some better pictures of that in a second. Here's another review article from Critical Care, this one with some echo pictures. And up here you can see the transesophageal view showing the cannula just here in the superior vena cava, and looking from below with a transcutaneous probe. Here's the cannula passing through the liver and just entering into the RA junction here. Same setup though, draining, pumping out through the oxygenator. Gas is being pumped through this. Usually we're using 100% oxygen with no blender on VV ECMO, and then blood is returned to the patient. This is what it looks like with a single dual lumen bicable cannula, where this close-up shows that blood is sucked out from above and below the right atrium, and then the second lumen comes in here and delivers blood back across the tricuspid valve. And the same sort of idea where we're taking blood, decarboxylizing it, oxygenating it, and putting it back relatively in the same place that we found it. This all works through the wonders of this hollow fiber membrane lung, shown in real life here on the left and in schema on the right, where blood is flowing in one direction and fresh gas is flowing through a permeable membrane, a semi-permeable membrane in the other direction. And it gives us a sort of a dialysis effect here, where we have deoxygenated blood coming in, oxygen goes across the membrane, CO2 goes in the other direction across the membrane, and then is returned to the patient in a new state. This gives us a nice separation, if you like, of CO2 control versus oxygenation control. When we have relative separation of those things with VV ECMO. If we want to control CO2, now we're talking about how much sweep gas we're using. So how much gas is flowing from the wall through the membrane. And once you have some blood flow, more than half a liter or a liter per minute, it doesn't matter what the blood flow is, your CO2 is going to be dependent on the amount of sweep gas flow. And as well as on the membrane function and the surface area. Oxygenation, on the other hand, as soon as you have some sweep gas, like as little as half a liter a minute, your oxygenation support is independent of sweep gas flow and totally dependent on the blood flow rate. And the reason for these two things is that because you'll remember that CO2 is very permeable and well dissolved in blood, whereas oxygen is not, and almost all the oxygen is carried and is dependent on being carried by hemoglobin. So because we can't get more than 100% saturated, having extra oxygen doesn't necessarily make things any better. And oxygenation on ECMO is all about matching blood flow. Again, in contrast to bypass, the heart is not stopped during ECMO. And in fact, during VV ECMO, the heart is still doing all the work that it would normally do. And therefore, the dependent amount of oxygenation that you're able to deliver is dependent on how well matched your ECMO blood flow is to the native blood flow or the cardiac output of the patient. And that matching depends more and more when the lung function is worse and worse. When somebody's totally dependent on ECMO, then you sometimes need to be able to provide up to 50, 60, 70% of their cardiac output in order to be able to maintain a reasonable saturation. And that can happen sometimes, as illustrated. Here's an X-ray of one of our prior ECMO patients, and as you can see, the lung has completely degassed, despite still being intubated and connected to the ventilator. So this patient is entirely dependent for their oxygenation and ventilation on the other ventilator in the room, the one that's on the ECMO circuit. So is this really empirically true? Well, here's some experimental data which just sort of shows what I said is true. Oxygenation is dependent on blood flow. On the left part of the figure here, here's ECMO. Here's here's the PCO2 and the PO2 at maximum flow. And as the flow is cut to 80%, 60%, and 40% of maximum flow, the PO2 drops precipitously. CO2 doesn't change very much. On the other hand, when we start manipulating sweep gas flow, and we go from 10 liters a minute down to 2, you see a significant increase in CO2 as we cut down the amount of sweep gas, no change in oxygenation because we're not changing the ECMO blood flow. You can also, in other experimental data here, see that the way that we're ventilating with the ECMO circuit influences the patient's own ventilatory drive. Here, these are patients who had a NAVA catheter, which measures diaphragm electrical activity in. And as the sweep gas flow on the ECMO is turned down from 4 to 2 to 0, you can see the amount of diaphragm electrical activity goes up, and it goes back down again as we turn the sweep gas back on. Same thing is transmitted here in tidal volume, as low tidal volumes up to higher tidal volumes as we turn the sweep gas off. And again, they reduce again when sweep gas gets turned on. So just important to recognize that when you have somebody on ECMO and on mechanical ventilation, they're connected to 2 different ventilators. And you may sometimes want to adjust how much ventilation you're doing with one to make sure that the amounts of efforts and pressures on the other one are within the desired range. I put this as this is one of the suggested readings for this webinar. Nice review from a few years ago by Alan Combs et al. And this figure just reminds us of some of the daily things one needs to do when we're looking after patients on VV ECMO. In terms of the general clinical management, as I was just saying, remember that using the ECMO ventilator allows you then to be very protective with the mechanical ventilator. Thinking about anticoagulation, and typically, although there's some uncertainty about this, typically we are targeting a PTT of about 1.5 to 2 times normal, but there's some uncertainty about what the right thing to do is for anticoagulation. And we'll talk about unanswered questions in ECMO and further on in the talk. But some people question whether anticoagulation is needed in all patients. Remember that there's the ECMO circuit, the big surface area, and some medications can get absorbed or sequestered by the ECMO membrane, and this might change the drug clearance or the volume of distribution. I mean, not so important for some medications where we're titrating to effect, but for some antibiotics, it may be important. And generally, when we have people on ECMO, we want to try and take advantage of the fact that we could potentially relieve them of the burden of sedation and bed rest and get them moving and even doing rehabilitation while they're on ECMO, although obviously experienced staff are needed for this. In terms of daily monitoring, this fits in on the other side here, thinking about monitoring respiratory drive and effort with P.1 or P occlusion in our patients daily, keeping a close eye on their fibrinogen platelets, their coag levels, and looking at the oxygenator and the membrane, and depending on which circuit you're using, some of them will actually tell you what the transmembrane pressure is on the ECMO circuit, which can be a sign that it's rising, that clots are starting to happen, and failure may be impending. Making sure all of our ECMO lines are secured and not moving about. Careful monitoring of the cannula sites. So that's the sort of general clinical overview of how ECMO works. Now I want to talk about why would we think it might be good for our patients. And I'll start with this historic study here, which almost put ECMO off the table before it even got onto it. This first randomized trial by Warren Zapol showing terrible survival rates, both in patients who did and who did not receive ECMO, with dismal survival rates of only 10% in this severe ARDS group in the mid to late 70s. But lots have changed since then. They used VA rather than VV ECMO, even though the patients had respiratory failure. They really anticoagulated everybody. They really didn't have the concept of ventilator-induced lung injury or lung protective ventilation at that time. And so I think that most people would recognize that these results don't apply in the modern era today. What changed our thinking? Well, and it certainly has changed. These are data from the ELSO registry showing adult ECMO runs, which were already starting to rise significantly pre-pandemic and have only gone up since then. Now, some reports. This is a JAMA paper from the mid '80s. Luciano Gattinoni just died earlier this week, unfortunately, and Ted Covolo showing that an extracorporeal life support system could provide very lung protective ventilation and survival in half the patients, as they showed here. And there were some early adopters. Bob Bartlett at the University of Michigan was a strong proponent, and you can see in their case series published here in JAMA 2000, a growing neonatal experience, and then into the 90s, increasing amounts of adult respiratory use, again with survival rates that were much better than that 10% ECMO survival that we saw from the Zapol trial. So that was setting the stage in the early part of the 21st century. And then a few things happened. First of all, in 2009, as you may remember, the H1N1 swine flu pandemic occurred and provided lots of young people with a lot of very severe single organ hypoxemic respiratory failure, some of whom were treated with ECMO. And secondary analysis done by propensity scores here showed significant risk reductions favoring the ECMO group. The study from the UK, there's similar ones from France and Australia. And in the same year, the first modern randomized control trial of ECMO was published in the Lancet, the seizure study here, showing a significant mortality advantage to a strategy of taking patients with severe ARDS and transferring them to a regional center to potentially receive ECMO. And you can see here, 53% mortality reduced to 37% in the conventional group. So, this was very encouraging data, I think they would say, but there were, it wasn't completely, I think that most people weren't sure that the answer was totally known at this time, because there were issues with this trial, for example. It's not, the numbers are relatively small. There may have been issues with not perfectly lung protective ventilation in the control group. And it wasn't a trial of straight ECMO versus no ECMO. It was transferred to an expert center to maybe get ECMO. And how much of that was the ECMO versus the transfer was not exactly clear. And at the same time, thinking about these H1N1 reports, this study on the left from Australia, 68 patients with H1N1 treated with ECMO, very young, very bad oxygenation. All of them got ECMO. At the same time, here's another patient series from this one from the United States in Utah. Again, same median age, similar PF ratio. None of these patients got ECMO, and their survival rates were almost the same. So I would say in the early 2010-11 region, I think some people thought that ECMO was definitely a good thing. Other people thought that really the question, the answer was still not clear. But what was clear is that its use was skyrocketing. Here's an analysis of the ELSO registry, and you can see that this really is exponential growth in the 10 years between 2003 and 2013. But the very interesting thing, and something of a cautionary tale to take from this, is that there was a very clear volume outcome relationship in these data, such that when you compared patients who were cared for in a center that did 5 or fewer cases of ECMO per year, there's a curvilinear relationship, which maybe seems to flatten out once you hit 30 or 40 cases a year. But if you're a patient, it seems like you certainly want to be somewhere where people are doing this regularly, not just once every couple of months. And on that background, the Aeolia trial was planned and conducted. And they had the study question here that's saying, in patients with very severe ARDS, does a strategy of earlier VV ECMO decrease 60-day mortality compared to usual care, including lung protective ventilation and prone positioning, reserving VV ECMO for only refractory hypoxemia? This was done in 249 patients were included and randomized between December 2011 and September 2017. 64 centers, most of them in France, but we had a couple of patients enrolled in Toronto. And all-cause mortality was at day 60 was the primary outcome. People got into this study with one of 3 criteria. They either had very low oxygenation for a relatively short time, pretty low oxygenation, PF ratio less than 80 for at least 6 hours, or they could have been difficult to ventilate with a pH of less than 7.25 and a PCO2 above 60 for at least 6 hours. And you can see the relative number who got in on these criteria. So a significant chunk, about a quarter of the patients got in with the difficult to ventilate criteria. They were enrolled within usually just a little bit over a day and a half from the time of being intubated on average. And importantly, more than half in each group had been proned for enrollment. They did a pretty good experiment in this trial. So most of the patients assigned to ECMO did get ECMO. Most of the patients in the control group did not, although some were rescued and did receive ECMO. And learning from prior studies, they, in the ECMO group, were very cognizant to provide, or trying to provide ultra-protective ventilation by turning down the tidal volume and turning down the plateau pressure, giving significant separation between the groups for the first several days of trial onset. You probably have seen these results. People joke that this is the most positive negative trial ever, the P of 0.07. If you're fixated on p-values, although recognizing there was a large amount of crossover, about 25% crossover rate between the control group being rescued by ECMO. These are all the secondary outcomes here, which mostly also go in the right direction. And if you look at crossover or death, then there's a very large reduction in the risk for that outcome. These are all the secondary or subgroup analysis that they did. I'll just pull one out for your attention, and that's baseline oxygenation. Interestingly, it wasn't the patients who were with the most hypoxemia who seemed to benefit most. If anything, it was the patients who were less hypoxemic, suggesting that it wasn't hypoxemia that was saving, that the ECMO was saving people from, but rather the problem was lung, the ability to provide lung protective ventilation and avoidance of ventilator-induced lung injury that was really the beneficial effect here. Another important point from the Aeolia is that this was done in experienced centers, and the complication rate was low. Only 2 versus 1 strokes, and in fact, more hemorrhagic stroke in the control group than there was in the ECMO group. So this is one of the editorials that accompanied this paper in the New England Journal, and they say something that's actually incorrect. They said that the routine use is not superior. That's not what this trial showed. It may or may not have shown that it wasn't, that it was better, but it certainly didn't prove that it wasn't. And this is when we start thinking about how we interpret trials. I like this paper in JAMA many years ago, but basically making the point that this is how, if we take a Bayesian lens to this, knowing the p-values is necessary, but not sufficient to know whether the hypothesis is true. This is why, although there's lots of trials and supposedly a very low p-value that says that homeopathy is good, I don't believe this, because there's no scientific basis for how homeopathy could work. And meanwhile, while in the other direction, while there may not be a great amount of scientific data or p-values, I kind of do believe that lung protective ventilation might work for prevention of for ARDS. And this is the Gordon-Rubenfeld rules of interpreting RCT results, aka how your inner Bayesian works. Either it's I already knew that, or I don't believe it. And the nice thing about Bayesian analysis, it just allows us to quantify this. So you and Gallagher did some nice work using the Aeolia results, and in a Bayesian reanalysis showed that for a wide range of priors, from minimally informative, strongly enthusiastic, or even quite skeptical, the posterior probability benefit, that the probability that the absolute risk reduction was 2 or 4%, is in the 80 to 90% range, which I personally would think that would be a pretty good indication to go ahead with something. At the same time, if you're not a believer in Bayesian analysis and you say, I really want to see frequent statistics, then great, no problem. We have a traditional meta-analysis here combining Aeolia and CSER together that Lavina and Munchie led, and you can see a 0.76 risk ratio that's well clear of the line of unity and is statistically significant for the p-value of 0.02. You include all the other observational data here. They all move in the same direction. The one outlier here is Tai Pham's study from France, but the caveat in this trial was that there were a lot of young patients in this propensity score who received ECMO that they couldn't match, and so therefore didn't include. And so I think these values have to be taken with a grain of salt. Of course, we saw a lot of ECMO being used as rescue therapy in COVID-19. This French experience here showing similar results and outcomes as we've seen in non-COVID ECMO, with about a 40% mortality rate. Similar findings later in a larger cohort from the ELSO registry here. The overall 90-day survival, 37%. So important to recognize that ECMO is a bridge and not a treatment. ECMO is a organ support system that may allow you to provide and avoid ventilator-induced lung injury, but it's not a treatment for the underlying lung disease per se. And when one is considering who to put on ECMO, before you even think about when to start or how to start, your thought should be, okay, what are my goals and how am I going to get the patient off ECMO? Is this bridge to recovery, which is what our target is in most ARDS patients? Is it bridge to transplant? Is it bridge to to a device if you were talking about VA ECMO? In terms of guidelines and recommendations, these are from the most recent ESICM guidelines, same meta-analysis results as we saw previously here. And they say essentially that we recommend using ECMO in ARDS patients who meet the Aeolia trial eligibility criteria, either those with PF ratios less than 80 for 6 hours, or who are difficult to ventilate for at least 6 hours, and that they should be treated in an ECMO center with good experience. I think clinically, this is still a nice algorithm that we wrote a few years ago, just in the early, just pre-pandemic actually, and says, start up here, take your patient, think about the underlying cause of their ARDS, treat that as you can, lung protective ventilation, look at their PF ratio. If it's less than 150, strong recommendation for prone positioning. Think about higher PEEP and neuromuscular blockade. And then once you've done all this, done all these things, then look to see, do they meet these Aeolia criteria? If yes, okay, are there any contraindications ECMO? If not, great, go on ECMO. But only after we've done all this. Same thing if the PF is greater than 150, is the patient difficult to ventilate? No, great, keep going. So the data, I think, on ECMO so far says that VV ECMO probably reduced mortality in severe ARDS patients who you've already tried to optimize their non-ECMO management. It needs to be done in expert high volume centers. Trying to do it only as rescue therapy would largely be infeasible. So there's a lot of additional questions about ECMO that we don't have the answers for yet. This is an opinion piece written 2017 by a group of experts saying here are top 10 questions we think need to be answered. Some of these have already been published since then. Aeolia came out after this, but just an example that there's lots of questions about how to do ECMO in whom to do ECMO. What's the best transfusion policy? How should we anticoagulate patients best? When and how should we mobilize and do physiotherapy on patients with ECMO? What are the best physiologic mechanical ventilation strategies to use when patients are on VV ECMO? And I would add to these, what is the threshold for starting ECMO? Because we know we have data based on Aeolia that those thresholds that they used will lead to those results. but we don't know necessarily if expanding criteria would also lead to benefits for patients. So lots of questions. How can we answer them? In a relatively infrequent disease such as severe ARDS, we probably can't rely on RCTs alone, or at least we need to find ways to conduct trials that are cheaper and more efficient, or that might require fewer patients. And part of this involves a rethinking of the traditional pyramid of evidence that, say, when we first started talking about evidence-based medicine, this was the dogma that observational studies and then randomized trials and meta-analyses of randomized trials were the peak. But I think now we're maybe moving on from that and saying we can have individual randomized trials, might have meta-analysis of these studies, and then the peak really is where we have both randomized and observational studies that are providing us with consistent findings. Even the FDA is recognizing that real-world evidence may be relied on more heavily than traditional outcome measures from clinical trials. And this is partly because we've seen a revolution in causal inference analysis. I recommend this book for anybody who's interested in a not too technical read about how this works. And Miguel Aynan from Harvard has published a lot about this and the idea of strengthening causal inference using target trial emulation, where you use observational data and try to set things up as much as a trial as possible. And there's some real life examples that this may work well in a number of settings. This paper from our colleagues in Michigan they'd just done a randomized control trial, but before this analytic team saw those results, they conducted their blinded target trial emulation of the same RCT, and as you can see, they showed exactly the same, but very similar results. And they make their point that this amount of work took 10 days versus 2 years of the actual trial. So we're not at a point yet where we can say that we should just do target trial emulation and not do randomized controlled trials, but we're very much interested in learning how target trials relate to actual RCTs, and we have a whole ongoing body of work built into Practical, led by Eddie Fan and Martin Erner, trying to get at this. Here's a target trial of ECMO used in COVID-19 patients that Martin Erner led, and showing a 7% risk difference if patients received ECMO when their PF ratio was less than 80. And interestingly, sort of a hypothesis generating way, looking at different thresholds for ECMO, when the PF ratio was between 80 and 120, a smaller, but still a significant difference of 4% in that group. So the other thing that we can do is thinking about designing better trials and blending the difference between quality and quality assurance, quality improvement, and clinical effectiveness research together by collaborations between industry, academia, and advocacy groups. A nice example of CF, but ARDS and acute hypoxemic respiratory failure may also work well here. By registries, and here's a well-established registry of called Intermax of ventricular assist devices that's led to a huge number of publications. And these are some of the ideas that are behind the index registry that Eddie Fan and Carol Hodgson are leading, where we're trying to get everybody who's put on ECMO into a research grade registry that will be available for both quality improvement and for embedded trials. Because once you have a great registry, you can start doing things like this example from Sweden, which was a randomized controlled trial of a new drug for PCI patients. They were able to randomize 80% of all eligible patients. And they did it with no loss to follow-up and a cost of only $400,000 compared to a projected cost of $10 million for a trial. So the incremental cost per patient for this randomization was only $50. And so that's one part of what we're trying to do with practical. And the other part is thinking about this concept of platform trials, where the analogy that Derek Angus likes to use is that we used to, when we wanted to study something, we'd say, okay, we have to build, we're going to have a football game, we're going to build a football stadium. So we'd build the stadium, we play the game, we put the whole trial infrastructure together, we'd run the trial, and then we'd knock down the football stadium again. And then next week we say, oh, we should have another football game, let's build another stadium. So the idea of the platform trial is we're going to build a stadium and we're going to keep playing matches there. And the difference is we have the ongoing infrastructure for trials and we keep subbing in new questions or new interventions as they go ahead and move along. This is really nicely illustrated in breast cancer in a phase 2 platform trial called I-SPY, set up by Laura Esserman, where they have had tremendous success in identifying potentially therapeutic options quickly and moving them to definitive phase 3 trials. Of course, platform trials play a huge role in our incremental knowledge over the pandemic with recovery and REMAP-CAP, bringing lots of new knowledge. And it's on this background that we've designed Practical. This was our practical schema about a year ago, where we have patients divided into 4 mutually exclusive platform states, from non-intubated low elastance, high elastance to ECLS. And then we have different domains that are active across varying parts of these states. So 42, the corticosteroid trial across all states, our extracorporeal CO2 removal trials, ultimate and proactive, being for patients who are intubated but not yet on ECMO, and the invasive mechanical ventilation strategies, potentially across all intubated patients here. And across all the domains, some nice embedded work with embedded physiology, translational science, Bayesian adaptive modeling, a registry, CRF, and clinical trial coordination. Since this slide was put together, the platform is looking significantly more complicated, as you can see here. We've had great success with a number of additional domains being funded. So here are 3 original domains that are up and running and rolling across the different states. Maybe we just turn this diagram 90 degrees. And now we have a number of additional domains, for example, inhaled furosemide for respiratory failure, led by John Muscaderi, using fludrocortisone to support blood pressure in patients with acute hypoxia and respiratory failure, a domain that Richard Greendyke, Lorenzo Del Sorbo, and Ewan Gallagher are leading, studying what the best ways to use the ventilator are in patients who are already on ECMO, and some nice collaborations there with our colleagues in the UK. We've got a global network set up for Practical, as you can see in the map here, and we have 44 sites, and maybe a couple of days out of bit late. These numbers are literally changing day by day. I think we're up to 46 as of today. Sites active. We'll be looking to have more than 100 sites enrolling patients in the not too distant future. This is just an update of what's happening so far. You can see in the IMB domain, we're starting, and in both and 42, we're just starting to see the exponential growth happening here with a sharp uptick in enrollment, more than 100 patients randomized in IMP. So I think I've tried to show you here in the last little bit of this talk, the future research in ECMO could be aided by the use of innovative trial designs, high quality registries, platform Bayesian adaptive trial designs, which is what we're trying to do in some of our domains in Practical. With that, I will stop, and I'd be happy to take questions either more focused on the basic application of ECMO or how we're studying it in trials. And I'll thank you very much for your attention.
I see a hand up from Carl. Please unmute yourself.
Yeah, hi Neil. That was a great talk. Thank you very much. Regarding the meta-analysis of the Eolia and Caesar trials, if I remember, they looked at the subgroups of patients with multi-organ system failure versus 2 or fewer organs, and the benefits seem to accrue to those with 2 or fewer organ failures. Can you address whether multi-organ system failure should be excluded from ECMO?
Yeah, it's a great question. I think that obviously we all are, both the clinical trial data, the observational data, observational data say not surprisingly that sicker patients are sicker and patients with multi-organ failure do worse. The harder thing to understand is what's the relative incremental benefit. Does that get lower when patients are sicker? It probably is less, but it's hard to know exactly where the cutoff is to say that we shouldn't put anybody on like that on ECMO. In our trial, we're trying to in our trial space, obviously we're trying to find the right balance of patients who are sick enough to potentially benefit without enrolling those who are absolutely destined to die no matter what we do. But I think there's still enough questions and uncertainty about this that the most important thing to do is to be collecting data about outcomes of these patients, whether they're in a trial or in a registry in real life, because that's really going to enable us to tease out what this incremental benefit might look like in the future. If you have questions, you can feel free to shout them out. If you're voice shy, you can feel free to put them in the chat. Hiroki, I see you online as our education fellow. Is there anything that we didn't cover here that you think we should essentially chat about?
No, thank you so much. I think we are all good. Just trying to double check. Yeah, thank you so much. I think it was a great summary of ECMO and also the heading towards a research agenda, so it was great. So yeah, just the chat.
Richard has a question in the chat here about spontaneous breathing versus an awakeness during ECMO. I think this is an interesting question. Actually, it applies both to patients on ECMO and also on a mechanical ventilator, even without ECMO. I think many people feel that moving the patient towards spontaneous breathing must be good because they're able to tolerate pressure support. And it feels like we're moving them in the direction of weaning. I think that depending on the patient, that can be challenging sometimes, and certainly there's some examples of spontaneous breathing leading to very large distending pressures being generated by the patient's own efforts in addition to the positive pressure from the ventilator. I think that the nice thing about ECMO is that we have another ventilator in the room, and we may be able to modulate respiratory efforts on the mechanical ventilator through use of sweep on the ECMO. Jose Diente has a nice paper about a physiological trial, essentially, of trying to get people into the sweet spot of being awake, spontaneously breathing, but not generating high pressures. And in a severely ill group of patients, he found that was very hard to do on patients who were not on ECMO. And in more than half the cases, when patients weren't on ECMO, he could only get them into the sweet spot using partial neuromuscular blockade. Whereas in about 80% of patients on VV ECMO, with a combination of both sedation, PEEP, and sweep gas manipulation, one was able to get them awake and spontaneously breathing. I'll just qualify that further by saying that all of these sort of are data based on what we think physiologically makes sense. We don't actually have any outcome data as yet about how important it is to limit high efforts on the ventilator, and especially when it comes at cost of sedation or paralysis. We don't know the absolute benefits or where the threshold of cutoff is. Definitely, we need to control efforts versus not, and we'll see with a lot of these trials ongoing hopefully what those thresholds are like. But I think that there are, if you hold 10 different ECMO physicians, they probably have 10 different thresholds for saying how much spontaneous efforts they are willing to tolerate with the patient being awake and breathing spontaneously or not. Hopefully that answers your question. I see another question from Natalie. So, are there any criteria that would automatically exclude a patient from receiving ECMO? I would say yes, but this is a bit of an evolving field as well. I think if we went back in time, you would see a list of both the relative and absolute contraindications to ECMO. And my sense is that a lot of things that used to be absolute contraindications have moved more to the relative contraindication process, but still, so things like duration of mechanical ventilation prior to starting ECMO, we used to be very strict about this, and now recognizing that may not be the 7 days or 10 days, that may not be a magical number about when somebody can recover or not. Similarly, older age has been a relative exclusion, and the truth is most of our trial evidence is generated from younger patients. There was a age cutoff of 65 in Eolia, so we're still relatively cautious about putting patients who are significantly older than that on ECMO, as it's a bit of a data-free zone. And generally, it's criteria where the patients have a very poor prognosis. And thinking about, as I said, what's your bridge going to be? Does the patient have a treatable disease that you can actually fix while you're resting their lungs on ECMO, or do they have if I would say, one example of a strong contraindication would be somebody who has a untreatable underlying pulmonary disease like IPF, who you knew from the start was not a transplant candidate. That would be a bridge to nowhere.
Any other questions? I think we have a couple more minutes. If not, can I ask one question? Like, I've learned a lot about the ECMO since I started working as a clinical fellow at TGH, as a ECMO center, as you mentioned. But like, what do you see the way forward to kind of capacity building of other non-ECMO center to become more familiarized with the ECMO, and how do you think practical trial platform can facilitate this process? If you have any thoughts on that.
Yeah, thanks, Hiroki. It's a good question. Certainly, the number of ECMO centers has expanded a lot in the last 3 or 4 years with the through the pandemic. How many of those will continue to do ECMO with any regularity is not exactly clear. I think one obvious way forward in this is to develop sort of some regional hub and spoke models where there's a large volume ECMO center. In our example in Toronto, that would be at in the GTA, the Greater Toronto Area, that would be Toronto General. And then there may be several other centers that could put somebody on ECMO. They may have the equipment. They have some cardiac surgeons and perfusionists around, and with consultation to our team, could initiate ECMO when necessary prior to transfer, and maybe manage a patient for a day or two with ongoing close collaboration. And we can move patients in both directions in that way. And that's one of the things, that's our strategy for, in a similar way that this happened in the Greater Paris region in Eolia. In Ultimate and Proactive, we're going to be screening patients at St. Michael's and Sunnybrook, for example, randomizing, and the patients who get randomized will transfer to Toronto General and get put on ECMO to facilitate extracorporeal CO2 removal and either ultra-long protective ventilation in the Ultimate group or early mobilization and liberation from mechanical ventilation in the Proactive group.
Any other questions? I don't see anything coming in the chat box. Okay. Yeah, Kathy put the form for the evaluation today. So if you could fill out the form, that'd be great. Kathy, can you make any closing remark or?
Yes, sure. Thank you very much. Thank you very much. That was a really good talk, really informative. I'd like to thank everyone here in the audience for joining today's webinar. And the second session of the webinar will happen after the new year, after the holidays. And emails will be circulated closer to dates. Thank you, everyone, for joining today's presentation.
Thanks very much.
Thank you so much.